Hello, this session I'll be discussing normal puerperium and care of the newborn. I'm Dr. Adego Kiadidokun Isaac. I'm a consultant obstetrician and gynecologist at the University of Medical Sciences Teaching Hospital, Ondo. So, our learning objectives: definition of puerperium, physiology of normal puerperium, management of normal puerperium, care of a normal neonate. Then we'll talk about kangaroo mother care. So, learner should be able to describe the various stages that occur in the mother during the puerperium at the end of the lecture. They should also be able to manage a normal puerperium, define essential newborn care, and state the steps involved in neonatal resuscitation. So I'll use this outline: introduction, physiology of the puerperium, principles of management of abnormalities, management of normal puerperium, then I'll end with care of the newborn. So by way of introduction, puerperium is defined as the time from delivery of the placenta through the first few weeks after the delivery. It's usually considered to be 6 weeks in duration. And by 6 weeks, most changes associated with pregnancy, labor, and delivery have actually resolved, and the body has reverted to the non-pregnant state. So now, compared to the antenatal and the intrapartum periods, the puerperium has received relatively less attention. So it's a period of often intense psychological and physical adjustment for the mother who has just delivered. And there may often be conflicts between beliefs, expectations by the society, caregivers, and of course, the patient. Up to 30% of women report major morbidities during the first 6 weeks postpartum. And we must note that many women may even die during this period. So, it's actually divided into 3 stages: the immediate puerperium, which is within the first 24 hours, early puerperium up to 7 days, then remote, that is up to 6 weeks post-delivery. So now, we'll talk about physiology of puerperium by considering the significant changes that occur in the uterus, in the cervix, in the vagina, in the perineum, the abdominal wall, ovaries, and of course the breasts. So now, at delivery, the dimension of the uterus is about 20 by 12 by 7.5 cm and approximately 1,000 grams in weight. After involution, it reverts back to non-pregnant size of approximately 60 grams. The isthmus becomes the lower uterine segment in a few weeks. Contour of the cervix is regained in 6 weeks. But we must note that the external horse never reverts back to the nulliparous state. So the endometrial lining rapidly regenerates so that by the 7th day, the endometrial glands are already evident. And by the 16th day, the endometrium is restored throughout the uterus, except at the placenta site. The placenta site undergoes a series of changes in the postpartum period. Immediately after delivery, the contractions of the arterial smooth muscle and compression of the vessels by contraction of the mammalium results in hemostasis. And of course, the size of the placenta bed decreases by about 50%. And the changes in the placenta bed also result in quantity and quality of the lochia that is seen. So now, in the postpartum period, a large amount of red blood initially flows from the uterus as the contraction phase rapidly occurs. The volume rapidly decreases. The duration of the discharge, that is lochia, known as lochia rubra, is variable. Rubra actually means red, so that's why we call it red blood. Then the red discharge changes to brownish red with a more watery consistency, and at this point is known as lochia serosa. And over a period of weeks, the discharge continues to decrease in amount and color and changes to yellow, which is known as lochia alba. The period of time the lochia lasts can actually vary, although it's between it averages approximately like 5 weeks. So pattern varies from woman to woman, with the various phases of the lochia lasting for different lengths of time. And up to 15% of women will have lochia even at 6 weeks postpartum. Occasionally, some women may experience an increase in the amount of uterine bleeding between 7 and 14 days due to shedding of the slough over the placenta site, but this is usually self-limiting. Now, how do you assess the involution of the uterus? The fundus lies about 13.5 centimeters above the symphysis pubis for the first 24 hours following delivery, and a steady decrease by 1 centimeter in the next 24 hours. By day 14, the uterus is no longer palpable per abdomen. It's now a pelvic organ, and this is completed by 6 weeks. So now, let's talk about the changes in the cervix. The cervix begins to rapidly revert to a non-pregnant state, but it never returns to nulliparous state. And by the end of the first week, the external os is closed to the extent that a finger will not be easily introduced. Then in the vagina, which was initially distended to accommodate the baby, shrinks to a non-pregnant state, but it does not completely return to its pre-pregnant size. The resolution of the increased vascularity and edema occurs by 3 weeks, and of course, the rugae of the vagina begin to reappear in women who are not breastfeeding. At this time, the vaginal epithelium appears atrophic on smear. This is restored by the 6th and between the 6th and the 10th week. But this can be delayed if the mother is actually breastfeeding because of the persistently decreased estrogen levels. So let's talk about the changes within the perineum. The perineum would have been stretched and traumatized, and sometimes torn or even cut during the process of labor and delivery. The swelling and engorged vulva rapidly resolves, and swelling and engorgement are completely gone within 1 to 2 weeks. Most of the muscle tone is regained by 6 weeks, with more improvement over the following few months. The muscle tone may or may not return to normal, of course, depending on the extent of injury. So let's talk about the abdominal wall. The abdominal wall remains soft and poorly toned for many weeks. The return to a pre-pregnant state depends largely on exercise. Then, the ovaries. Resumption of normal function by the ovaries is highly variable and is greatly influenced by breastfeeding the infant. Exclusively breastfeeding mothers have longer periods of amenorrhea and anovulation. Non-lactating mothers may ovulate as early as 27 days after delivery. The mean is 70 to 75 days, and most women have a menstrual period by 12 weeks, the mean time being 7 to 9 weeks. In the breastfeeding woman, the resumption of menses is highly variable and depends on a number of factors. How much the baby is breastfed, how often the baby is breastfed, whether the infant's food is supplemented with formula or not. Then the delay in the return to normal ovarian function in the lactating mother is caused by suppression of ovulation due to the elevation in prolactin. Up to half to 3/4 of women who breastfeed return to periods within 36 weeks of delivery. So, as I mentioned, the mean time for the first menses is 7 to 9 weeks, and in exclusively breastfeeding mothers, risk of ovulation within 6 months is 1 to 5%. So now, let's talk about maternal weight. By 6 weeks, 28% of women have returned to pre-pregnancy weight. Latest 6 months for women with weight gain of less than 15 kilograms. With excessive weight gain, that is greater than 15 kilograms throughout pregnancy, it may take longer for the woman to return to her pre-pregnancy weight. So now, the breast. Breast changes that prepare the body for breastfeeding occur throughout pregnancy. In fact, it's been said that lactation can occur by 16 weeks gestation. Lactogenesis is initially triggered by the delivery of the placenta, which results in falling levels of estrogen and progesterone with the continued presence of prolactin. If no breastfeeding, the prolactin levels decrease and return to normal within 2 to 3 weeks. The colostrum is a liquid that is initially released by the breast during the first 2 to 4 days post-delivery. It is high in protein content. This liquid is very protective for the newborn. And the suckling by the newborn triggers the release of colostrum. The process begins as an endocrine process, later autocrine, and of course, the removal of milk from the breast stimulates more milk production. Over the first 7 days, the milk matures and contains all necessary nutrients in the neonatal period. The milk continues to change throughout the period of breastfeeding to meet the demands of the baby. So in essence, changes in breast and lactation can be divided into mammogenesis. Mammogenesis, which is growth of the mammary gland duct and development. Then lactogenesis, that is initiation of milk production within the alveoli. Then galactopoiesis, that's maintenance of lactation. And of course, removal of milk from the gland is galactokinesis. So now, how do you manage a normal puerperium? The aim is to restore the health of the mother, prevent infection, take care of the breast and promote breastfeeding, then motivate the mother for contraception. So what do you do to restore the health of the mother? Encourage her to rest and ambulate early. Then support her emotionally. She must be given a diet of her choice. Then sleep adequately. There should be maternal-infant bonding. And of course, postnatal exercise is important. Now, to prevent infection, there is need to care for the bladder and the vulva. There is need to care for the episiotomy wound. Then maintenance of asepsis and proper hygiene. Then there is need for immunization. Now, treatment of minor ailments. They may complain of after pains, uterine massage will help, analgesia, occasionally antispasmodic. Then, when there's pain on the puerperium, sitz baths, which will give a soothing relief, analgesics. Then, if there's anemia, then we need for supplementary iron therapy, and occasionally, then we need for blood transfusion. So, now, by way of conclusion, knowledge of the normal puerperium will help in identifying abnormality early in order to offer prompt and appropriate management. Now we discuss care of the newborn. So now, by way of introduction, across the globe, 3.1 million children die each year in their neonatal period. That's according to WHO in 2011. And half of these deaths occur within the first 24 hours of delivery. So that period is very critical. 75% occur in the early neonatal period, and most deaths are due to preterm births, severe infections, and birth asphyxia. And one of the targets of MDG was two-third reduction in infant and child mortality by 2015, and we are even talking about SDG now. So, WHO recommended essential newborn care practices to reduce the risk of the main causes of neonatal deaths in both community and facility deliveries. So, what is essential newborn care? So, essential newborn care is a comprehensive strategy designed to improve the health of newborns, through interventions before conception, during pregnancy, at and soon after birth, and in the postnatal period. So we must know and have this at the back of our minds that most babies are born healthy and are born at term. Care during the first hours, days, and weeks of life determine whether they remain healthy or not. And basic care to support survival and well-being is what is called essential newborn care. And it includes immediate care at birth, care during the first day, and of course up to 28 days. So now, what are the basic needs of a newborn? To breathe normally, to be protected, to be warm, and to be fed. So what are the interventions of essential newborn care? Clean childbirth and cord care. This will prevent infection in the newborn. Thermal protection. This will prevent and manage newborn hypo or hyperthermia. Early and exclusive breastfeeding, which must be started within 1 hour after childbirth. The initiation of breastfeeding and resuscitation. This will help in identifying asphyxia early and managing appropriately. Then, of course, we should employ, these are the things we employ: universal precautions and cleanliness, as wash hands, wear gloves, practice safe sharps disposal, practice safe waste disposal, sterilize and clean contaminated equipment, among other things. Then now, preparing for birth. How do you prepare for birth? Because you don't wait until you give birth to the child before you start practicing essential newborn care. You wash your hands, then essential equipment and environment has to be drop-free, warm room, temperature at least 25 degrees Celsius, a clean, dry, and warm delivery surface, a radiant heater, 2 clean, warm towels, clothes to dry wrap or cover the newborn, a folded piece of cloth, a suction device, laryngoscope, oxygen, medications, and even clock. So now, how do you care for the baby at the time of birth and until about 1 hour after birth? You have to provide routine care for all newborns. And in fact, you must have a protocol, a departmental protocol to do this. Then you must identify and manage newborns who may need special care. So now, what's the routine care? As soon as the baby is delivered, you have to call out the time of birth, place baby on mother's abdomen. You have to dry baby with warm, clean sheet, wipe mouth and nose with clean clothes, assess baby's breathing while drying. Then you must clamp cord within 1 to 3 minutes. You cut with sterile instrument, then you put a sterile tie. Then you must put a label to identify the baby. So now, routine care. You have to examine for malformations, birth injury. Then you have to initiate breastfeeding within 1 hour. Record the baby's weight. Routinely give injection of vitamin K, 1 milligram IM, and for preterm, 0.5 milligram. Then cover baby's head with cloth. Then you cover mother and baby with warm cloth. So for resuscitation, all babies must be assessed for need of resuscitation at birth. And at least one person skilled in providing resuscitation must be present at the time of delivery. And you must start ventilation within 1 minute of birth, which is called the golden minute. So this is the chart, the flow diagram for resuscitation. You have to know the time you receive the baby, and you have to receive the baby in dry, warm linen. You have to assess, is the baby crying or not? If yes, go through routine care. If no, cut cord immediately and place under radiant warmer. The initial steps, and you assess like that. Yes, you assess following the chart. You initiate PPV using here. Then again, from the delivery room, you have to decide, does this baby need admission or referral, depending on the facility you have on ground. The baby will need admission or referral if the birth weight is less than 1,500 grams, or if the baby is less than 34 weeks most of the time. Then if the baby has a major congenital malformation, then if there's severe birth injury, the baby is in respiratory distress, and your PPV is administered more than 1 minute, or the baby even needs chest compression or drugs, then you can employ observational care if the birth weight is between 1,500 grams and 1,800 grams. Then if the babies need PPV less than 1 minute and baby is vigorous. So you clamp and cut cord with a sterile instrument. That's immediate cord care. And observe for oozing blood. Do not apply any substance to stump. Do not bind or bandage stump. So you should leave the stump uncovered. You can see the diagram that illustrates that. And these are the ways by which the baby can lose heat: through convection, evaporation, conduction through the surface, then radiation. And of course, this is the explanation ways by which a baby can, how to prevent heat loss. Evaporation, if the baby is wet, so you should clean the baby, make sure the baby is warm. Then through conduction, you should put the baby on mother's abdomen or on a warm surface. And convection, you should provide a warm, draught-free room for delivery, at least greater than 25 degrees Celsius, as I mentioned earlier. Then radiation through cold metallic surroundings. You have to keep the room warm. So now, I'll just talk briefly about kangaroo mother care. In kangaroo mother care, there's skin-to-skin contact. And of course, any family member can do this. It doesn't have to be the mother. If the mother is not strong enough to do it, maybe following cesarean section or a complicated delivery, then it's done not less than 1 hour at a time. And it's very useful for low birth weight. It provides warmth. Then it promotes breastfeeding, protects from infection, emotional bonding, physiological stability. It reduces apnea and multimodal stimulation. So now, warm chain, you have to maintain the warm chain, warm delivery room, immediate drying, skin-to-skin contact at birth, breastfeeding too. Then bathing and weighing should be postponed. Then appropriate clothing. Then mother and baby should stay together. Then if you have to transport, let the environment be warm. So now, breastfeeding. You have to help mother to initiate breastfeeding within 1 hour of birth. You have to help mother at first feed. You have to ensure good position, good attachment, and effective sucking. Then in the postnatal ward, you have to keep, the postnatal ward has to be kept warm. The mother and her baby must be kept together in the same bed, which we call rooming in. And this helps to form bonding. And when the baby wants to feed, the mother can respond quickly. And breastfeeding difficulties are often reduced. Then you have to engage the mother. Ask her, do you or your baby have problems? Has your baby passed stool or urine? Have you started breastfeeding your baby? Is there any difficulty in feeding your infant? Do you have any pain during the process of breastfeeding? And is your baby getting meal other than breast milk? And what is the baby getting? And how is the baby getting it? So you have to examine the baby in the postnatal ward. You should count the breaths in 1 minute. Look for severe chest indrawing. Look and listen for grunting. Look at the umbilicus. Is it red? Is it draining pus? Look for skin pustules. All these are very important. Is the baby lethargic? Is the baby jaundiced? The face, abdomen, or soles, are they yellow? Then look for malformations. These are very important. Then you should assess breastfeeding in the postnatal ward. Assess whether the baby is feeding well or not. Observe the way the woman is breastfeeding for at least 4 minutes. Is the infant able to attach? And to check for attachment, is the chin touching the breast? Is the mouth open widely? Is the lower lip turned outward? Then do you have more areola above than below the mouth? So, if there's any abnormality, you should correct appropriately. So, these are some of the normal things that the mothers complain about, and we should be familiarized with this. Milia, Epstein pears, Mongolian spots, enlarged breasts, capillary nevi, etc. They complain about this. Then transitional stools, vaginal white discharge or bleeding in female babies, red rashes on skin, 3 days of life, then weight loss of 6 to 8%, and maybe as high as 10 to 12% even in preterm infants in the first few days of life. These are normal phenomena. They will complain about these things, but you have to allay their fears. So cord care, the umbilical cord is important. Portal of entry for pathogenic organisms. So you have to take good care of the cord. Then you have to instruct the mother not to apply anything on the cord, and the cord has to be dry. Then you have to inspect the umbilical stump after 2 to 4 hours of clamping. So you should care for the skin and the eye of the baby. So counsel the mother to keep the baby warm, breastfeed frequently and exclusively, advise mother to wash hands with soap and water after using toilet and after cleaning bottom of baby. Advise mother regarding danger signs, and of course, they should seek care. So immunization for the baby is important. Then there's need for follow-up. So by way of summary, basic care to support survival and well-being is essential newborn care. Ventilation must be initiated within first minute of life, and you must help to initiate breastfeeding within first hour of birth. Then identify and refer neonates requiring special care. Then you must take all precautions to prevent infection, hypothermia, and counsel mother for the same. Then the mother must be counseled for danger signs, immunization, and the need for follow-up. Thank you.